Good morning, everybody. At the outset, I would like to thank Dr. Jayakrishnan sir and the Advance 2023 for this invitation and giving me this wonderful opportunity. So all this while we've been hearing all about endometriosis, the medical management by Dr. Fezzi Lewis, beautifully covered, and the surgical management by Professor Justin Clark. So when it comes to dealing pain with endometriosis, it is going to be a combination of these two modalities. And of course, like how pain in endometriosis is a pain for the patient, it is also a pain for the treating gynecologist, because invariably, how much ever we try, at times we are at a crossroad wondering whether we are doing the right thing for the patient, whether she is really benefiting out of it. So let's look at how are we going to manage women with pain in endometriosis. So endometriosis, because of its complexity, there is always a constant debate as to how to optimally manage these women with pain in endometriosis. So medical management can provide only temporary relief, but most of the time they will be able to achieve much better relief when medical management is combined with surgical modalities. So why exactly the women is having pain during endometriosis is because we need to understand the underlying biochemical abnormalities and also the therapeutic targets. So invariably it will boil down to the same concept of exaggerated inflammatory responses and excess production of the estrogen, progesterone resistance. So ultimately the critical underlying mechanism that leads to the symptoms of endometriosis needs to be addressed. So why every other woman does not develop endometriosis? So there's so much of reflex menstruation happening in every other woman, but then not all women develops endometriosis. So this is because these endometriotic implants, they will impair the molecular and the immunological function, and there is an increased production of the estrogen pro-inflammatory markers like the cytokines, the prostaglandins, matrix metalloproteinase, and the failure of the immune system to suppress and clear these inflammatory responses. So when there is an inflammatory and immunological dysfunction, that is when she develops endometriosis and the pain associated with it. So there is an overload of estrogen. So it is the culprit. So this constant supply of estrogen is crucial for the growth and the persistence of the endometriotic implants, which come from multiple sites. So the endometrial implants, they have intrinsic aromatase activity, which leads to the conversion of the cholesterol to estradiol, and which is the active form of the estrogen. Now, the endometrium per se is very rich in the prostaglandin E2 receptors, and the activation of these prostaglandin receptors lead to the activation of cyclic AMP and invariably increase in aromatase activities, and finally which causes an increase in estradiol secretions, and which makes the endometriosis grow further. Now there is also an increase in prostaglandins in these women, and this is especially the type to E2 and F2 alpha. Now, cyclooxygenase is the it catalyzes the conversion of the arachidonic acid to prostaglandins H2, which is converted to E2 and F2 alpha via the action of PG synthetase. Now, this overexpression of cyclooxygenase in very high concentration in the endometriotic implants is mainly responsible for the growth of the endometriosis, and also there is an increased concentration of prostaglandins E2, which also produce a stimulus for estrogen production. Apart from that, the inflammatory markers, the cytokines, and also the VEGF and COX2 expressions, all these are also increased, which causes the endometriosis to grow further. And of course, as highlighted earlier, also the progesterone resistance also plays a very major role, because the endometriotic lesions, they have a very low progesterone receptors level, and progesterone is very important for the activation of the key enzyme 17-beta hydroxysteroid dehydrogenase, and this helps in converting the estradiol to estrone, which is less biologically active. So thus increased production of estradiol and decreased clearance leads to the growth of the endometriotic tissues. So the pathophysiology of the endometriosis-associated pain involves mainly the inflammation, hormonal alterations, and also the change in the pain signaling pathways. So ultimately, all this results in fibrosis. So this is a reason for the pain, and it has been found that none of the medicine seems to be penetrating through the fibrous tissue. That is the reason why women seem to be resistant to the medical management at times, and then we have to combine a surgical modality to it. So of course, now we all know the fetal origin of this endometriotic disease because of the reflex menstruation, which starts way back in the fetal period itself, but then they remain dormant. Only when the genetic and the epigenetic changes takes place at the time of puberty, this endometriotic lesion flares up, and this has been very nicely understood these days. And also, apart from that, the repeated ovulation is the indispensable factor for endometriosis, and our treatment is mainly to prevent the interruption of the ovulation, which is the main hallmark in the treatment of endometriosis. So the women now presents with acyclical pain, and it has been found that the intensity of pain is not directly proportional to the severity of the endometriosis. Many a times the women will have just a surface endometriosis, but she may be having excruciating pain. There are women who have deep infiltrating endometriosis are coming to us at very later point in life. That means their pain tolerance have been really good. So this, when in understanding pain in endometriosis, we need to understand that the pelvis is highly innervated, which is why the pain impulses are processed and sent to the brain. And also the peritoneal fluid, they also contain quite a lot of nerve growth factors which all promote angiogenesis. Now these cytokines and the prostaglandins, they are mainly produced by these mast cells, and the inflammatory cells are attracted towards these endometriotic cells, and they activate the nerve fibers and trigger the nearby cells also and cause inflammation and pain. So it has been found that even wheelchair-bound patients, they are free from pain once the endometriotic lesions which have infiltrated the nerve bundles like the lumbosacral trunk, all those things have been dissected these days to relieve the pain from endometriosis. So ultimately, endometriosis-associated pain is mainly caused by peripheral and central activations. All of us are concentrating only on the peripheral and ignoring the central activation of pain. And initially, they have only nociceptive pain, which is mainly dysmenorrhea and cyclical abdominal pain. But only the later stages, they develop into the nociplastic pain, which is also dyspareunia, and they end up with chronic pelvic pain. So ultimately, when it comes to the management of pain in endometriosis, we have empirical treatment, medical treatment, surgical treatment, a combined medical and surgical treatment, and ultimately it all depends on what exactly her problem is, whether it is the pain or infertility. So it is a chronic and incurable disease. How much ever we treat, there is a chance for recurrence for this particular condition, and when it comes to managing pain, we have to take a proper history and make sure we rule out all of these things, and it is invariably a holistic treatment where we have to combine other modalities also to give her some kind of a relief at time. So when, of course, the medical aspect have been beautifully highlighted by Dr. Fezzi Lewis, but then when it comes initially, we start them only in non-steroidal anti-inflammatory drugs because we know these block the COX enzymes, and that is crucial for the production of the inflammatory mediators, and that is why non-steroidal anti-inflammatory drugs are working. The most effective one will be rofecoxib, which has been found to be quite effective in endometriotic pain, and also primarily they affect the central nervous system's modulation of pain rather than the peripheral modulation of the inflammations. That is how they are found to be quite effective. So when they are not responding to non-steroidal anti-inflammatory drugs, then we move on to the next modality, which is the hormonal pills, which is the oral contraceptive pills. If you are going to give an oral contraceptive pill, it is always have to be continuous, and always make sure that the estrogen content in the pill is less than 20 microgram. So because basically these are hyperestrogenic conditions, the threshold of estrogen of 50 microgram, there is a tendency for the endometriosis to flare up. So always it is better to use a 20 microgram oral contraceptive pill so that the disease is brought under control. Of course, these are the various other hormones which we can also offer. And are these hormone therapies effective for pain? So mainly these hormonal therapy, they modify the hormonal, medical management, they modify the hormonal environment either by suppressing the ovarian activity or directly acting on the steroid receptors and enzymes and found in the lesions. And it has been found that there is no evidence of superiority of one hormonal treatment over the other. So certain medications may work better in some individuals while others will work better in another individual, but whatever it is, continuous OCP should be offered, though it is a weak recommendation by the ESHRE latest guideline. So the progestin and of course anti-progestins Cochrane review by Brown et al. Is the most recent Cochrane review, where they also believe that continuous progesterones and continuous gestaron are effective therapy for treatment of painful or symptoms associated with endometriosis. And of course, the progesterones, they have multiple actions that form the pathophysiological basis of its use in endometriosis by deserialization of the endometrium and also by estrogen-induced mitosis and also by altering the estrogen receptors and also by inhibiting angiogenesis and the expression of matrix metalloproteinase, which all are needed for the growth of endometriotic implants. So the theory behind their success in women with endometriosis is progesterone induced, which has been already highlighted. And of course, this is found to be quite useful in most of the women with pain endometriosis, in women who have completed the family, the levonorgestrel intrauterine systems. I think abroad they are using it even for unmarried women, because most of the girls, they feel because they are sexually active can be used with, because this is found to be a wonderful molecule which does not cause much discomfort to them, and it is found to have a great relief in endometriosis associated pain. And also in case of defiltrating endometriosis, after the surgery, the women can be put on levonorgestrel intrauterine systems. So these are the various literatures where they have found that LNG-IUS reduces the pain score with no difference occurred compared to that of GnRH analogs. So of course now the ENG implants, that is the Implanon, which is being used for oral, contraception, have also been tried for pain in endometriosis. Though I do not have, though I use it for contraception, I do not have any experience on endometriosis. And of course the danazol, we do not use it because of the side effects. And of course GnRH agonist has been found to be again quite effective when it comes to pain, for especially in case of deep infiltrated endometriosis and also when it is associated with adenomyosis. So GnRH analogs and add-back therapy is a must when you are using it, but try to avoid it in girls less than 18 years because of the side effects. And antagonist is also found to be a very good molecule, elagolix. Though it is available abroad, in our country it is not available, but then this along with the add-back is found to be quite effective. Of course, aromatase inhibitors again is very effective for perimenopausal women, and when none of those other agents work, aromatase inhibitors have been found to be quite effective because of its action on the aromatase enzyme. And of course, many a times you see that there is no bleeding, but still the pain persists in spite of all the hormonal therapy. So in such cases, if the woman is on oral contraceptive pills, we have to immediately switch over to some other things. So the progesterone would be the ideal choice. And in POPs, if you see, the estrogen level usually remains within the therapeutic window. As I mentioned earlier, the therapeutic window is about 15 micrograms, and you should not go beyond this. So that is a reason while you are using oral contraceptive, always use a molecule which has less than 20 microgram. So in this context of chronic pain, GnRH analogs is superior to Dynogest, and it should be used as a second-line therapy with add-back HRTs. So how long can you give these hormonal therapy? If signs of improvement are there, after 3 months, the therapy should be extended for 6 months. So minimum at least 6 months duration is what is needed to see whether the treatment works. So many times, in spite of medical management, if they are not responding, then we have to go for the surgical management. where the best surgical approaches would have to be followed to make sure there is not much damage to any of the vital structures. So this is a case where in fact, she has completed the family and she came with all these blebs, endometriotic blebs in the pouch of Douglas. So this was the reason for her pain. None of the medicines was working, so decided to go for the surgery. So we did a excision of all these, and so if you can see, the ovaries are perfectly normal, and there are only blebs. And so sorry for the slight technical hitch. So these kind of endometriotic blebs, unless and until we excise it, she will not have any relief from pain. So we have to meticulously dissect all of these, and the most important thing is, while the other structures are pretty normal, she doesn't have anything else apart from the superficial endometriosis. We have to collect all of these blebs, put it inside the bag, and make sure you remove all of them in toto, so that you do not leave any deposits here. So few of the blebs had also gone right into the bubble, so you have to excise it completely and make sure that the entire pouch of Douglas is free from all these lesions, so that she will have some pain relief. So with this, she settled very well, and she did not require anything else after that in the post-operative period. So many a times, even endometrioma, of course, there is a real controversy whether to manage it medically or by surgery. Of course, surgery has to be done in certain situations, especially when the woman is having pain. The very fact that she has an endometrioma itself indicates that the disease has progressed to the next level. It is no longer a mild disease. In such a scenario, it is better not to wait too long, because the longer, even in a case of fertility, it is a debatable topic, but then the longer you wait for an endometrioma, it is going to have more damage on the cortex, and it is going to be very deleterious for her fertility, because it is not all about reduced ovarian reserve. In women with endometrioma, they have also also found that there is a drastic decline in the ovarian reserve compared to that of the normal ovaries and the normal ovarian cyst. So that is the reason why a women with endometrioma, we need to remove them and not wait too long for the deleterious effect of the endometrioma to happen onto the adjacent cortex. So in these cases, if you remove all of these and then maybe follow her rub, she will have tremendous relief from pain. So we need to combine the medical with the surgical in scenario like this as well. And this is again, you can see that hysteroscopic finding of a girl. In fact, she was a case of an adolescent endometriosis, huge endometrioma, bilateral with severe pain, so had to operate, and then now had put her on Dynogest, and then she got married, and immediately after marriage she was anxious that she wanted to have a baby. So did a hysteroscopic, and this was the finding. So in spite of being on Dynogest for almost 3-4 years, you can see how the endometriosis, so this is the entire junctional zone was affected by the endometrioma. So of course she did not have any recurrences, but there were a lot of adhesions. So mainly because of the inflammations which has happened because of the endometriosis. So in these cases, again, she will have pain because you have to release all of these adhesions, and then you have to manage her accordingly based on her indication. So here she was very keen on having a baby, so immediately we can start her with the fertility treatment. So of course, Luna also have been tried for fertility, to give relief from pain, but then because of all the complications associated with Luna, like the uterine prolapse and the ureteric damage, it is not very widely taken up. And of course, pre-sacral neurectomy has also been tried, and it is found to be quite effective to give relief from these pain. And of course, now when it is associated with the rectal endometriosis, again, unless and until you manage them surgically, we are not going to have any pain relief. But while managing rectal endometriosis, we also need to take care of the sympathetic and the parasympathetic nerve involvement, so that you do not compromise on the rectal function. So shaving and excision and disc resections are rather better than that of segmental resection. So again, it all depends upon the size of the lesion. So discoid excision had no impact on the aerodynamic or the anorectal functions, but pain scores improved post-operatively. And again, the discoid resection should be the first choice in rectal endometriosis with unifocal endometriotic lesions which are less than 3 centimeters. But if the lesions are more than 3 centimeters, you have to go for a segmental resection. So these are the few surgeries you have already seen from Dr. Justin Clark's video. So I think I will forward it for want of time. And again, shaving versus discoid versus segmental resection, it is better to be as conservative as possible so that you do not damage the rectal functions. And again, apart from significant improvement of pain, radical treatment of deep infiltrating endometriosis also positively impact the fertility outcome. That is why in DIE patients with infertility, they conceive in fact after the surgeries. And of course, bladder endometriosis also need to be tackled because it is not an isolated condition. Invariably, they will have an ureteric endometriosis, and these are the things where you have to tackle them appropriately to give them relief. And this is again a case of which presented as bladder endometriosis, but when with bilateral endometrioma, but when I did a cystoscope, it was looking like a fluffy growth inside the bladder. So it turned out to be a polypoidal growth in the bladder, and it was not an bladder endometrioma. So we resected the growth cystoscopically with the help of a hysteroscope resection, and the endometrioma, the growth was removed. And of course, these are the last resort. Ultimately, when they do not respond to any of these things, you have to do a hysterectomy. And while doing a hysterectomy, again, we need to take care that you do not damage the nerve. Nerve sparing hysterectomy is what needs to be done in such cases. And of course, when in such a scenario, better to also remove the ovary and put her on post-operative hormonal therapy. If she is really, really young, after a period of time, watchful expectancy is first needed. And alternative therapies have also been tried, like acupuncture. So to conclude, so managing pain in endometriosis is a challenge. There is no clear answer because therapy must be personalized for each patient and depends on the women's goal. So particular attention must be paid to the management of the patient with DIE, and surgery should be done at the right time that matches the needs and desires bias, and women should be educated about endometriosis and given easy, accessible information to improve the treatment adherence, to improve her quality of life. So thank you so much for the patient listening.